I'm Steve Cohen, and this is the first executive grand rounds of the calendar year, kind of 2016, and it's a very particular, special kind of executive grand rounds. We're going to have Dr. Mark Rubin, Humber Hurst Professor of Pathology and Englander Director of the Institute for Precision Medicine, speak to us this morning. And what Mark is going to be describing is very much cutting-edge medicine and very much emblematic of what we mean when we talk about going from bench to bedside and back again. What Mark has had to orchestrate in order to kind of make this program a success, and it's very much a success, is an incredibly complex kind of organizational symphony of scientists in pathology, oncology, technicians and technologists in the hospital, in the college, computational individuals working in the college, working at the Genome Center. In addition, because of its high profile and potential kind of import, this is a highly politicized area. So we've got the Genome Center that wants to do a lot. We've got Columbia University, which wants to do a lot. It's also an area in which there's an enormous amount of hype. And one of the things I'm hoping Dr. Rubin is going to get into today is how we, as educated lay people, as administrators here at Weill Cornell, can begin to understand what is hype and what is kind of reality. So the Institute for Precision Medicine is something that kind of Mark is going to talk about, and it's very much about how we can bring kind of breakthroughs in our kind of laboratory research to kind of the oncology clinic. Okay, so with no further ado, I'm going to introduce Dr. Mark Rubin.
Well, actually, thanks very much for the invitation. I didn't realize you were a singer, entertainer as well. And so I'll try to give a presentation I think will be interesting to a crowd that is not basic scientists. But I also appreciate that I've given versions of this talk over a number of years now, and we're seeing it's really changing very quickly. So this concept of precision medicine 3 or 4 years ago when we were talking about it was not even on the radar. And last year President Obama talked about it, and I'll discuss that a bit. But the idea is that it's really something that is found its time, and as Steve said, I think because of investments into this early on, I think we're in a wonderful position to be leaders in the field. I'm told by our administrators we always have to have a disclosure, so here's our disclosure. And we've established a website which you can visit, and there's some very nice videos, and we're obviously trying to improve that all the time. So the concept of precision medicine is one I just want to lay out before we go into this. And the idea is that it's not, today I'll be focusing predominantly on cancer precision medicine, but really the idea of precision medicine affects all areas of healthcare. So it's in the well state, it's when you're sick, it could be if you have diabetes, hypertension, how you respond to a drug for various types of common illnesses or advanced diseases. And the framework was laid out by the National Academy of Medicine a few years ago, and the concept was that we already take care of patients well, but in order to improve, we want to align the clinical care that we give with the types of molecular testing that was emerging. So sequencing of the human genome and performing genetic tests. How can we align that with all the other information that is accumulating? And so the idea was that in the context of clinical care, we would align this genomic testing. And I think as I've given this talk over the years, past 3 years, let's say, what was perceived as purely research, I think 3 or 4 years ago, now is really being, I think, very well integrated into clinical care. Now, the concept really for this precision medicine is that as you do this in real time and you feed back iteratively the information you get from the sequencing, from what happens to a patient, we're going to learn more. And it's not really just about the one event, it's about following the patients in the course of their healthcare. So that's what we're thinking about. And I know it affects people at every stage of their disease. And so hopefully what I'll tell you will be relevant And also, I think as administrative leaders, hopefully we'll be able to, and at the end I will have an ask to help empower this activity, but I think it's a reasonable ask from what I understand. So every time I've prepared a talk in this area, I usually look at the New York Times in the morning, and I see there's usually some piece of information. This was when I spoke to the medical students. It happened on whatever, this was December 15th, I think that day. Almost every day there's something in the news about precision medicine. Here's an example of identifying the fact that there's varied fees that are requested for certain procedures. In this case, it's knee replacements, but it could be any other type of hip replacements or whatever. And you know, what causes these tremendous variations in charges that we see in the United States. The discussions, I think, framing this in a sort of a larger perspective, and when you talk internationally about precision medicine, one of the issues that comes up over and over is that the United States spends a lot of money on healthcare, but yet by a number of metrics, we are not the country with the longest life expectancy or the healthiest population, and we could debate that. But typically, we're viewed as a country that spends a lot on healthcare. In trying to explain this to the Swiss, you know, I pointed out that we don't have universal health care, and we're moving towards it, but we don't have universal coverage. And so that's something where we've gone from poor coverage to now hopefully a little bit better, but we don't have that. And the other, you know, aspect is comparing the United States to other countries is obviously we have multiple healthcare providers and insurers, which typically in a country like Germany or Switzerland, they have a single governmental or non-profit insurer. And so that obviously creates a lot of complexity, because for precision medicine to work, we have to develop something that's an accepted standard of practice. And I think that's one of the main issues for getting the costs of precision medicine down. We have to start accepting what tests that we're going to be providing. I'll give you some examples, how they fit in. And if you read recently Vice President Biden's comments on precision medicine or this moonshot initiative, what you'll see coming out is when asking the experts, you know, how is this going to work? I mean, one of the issues is that a lot of what we're doing is not standard of care, and it's viewed as research. And so that's something that we have to bridge this divide, and I'll talk a little bit about that. The example I give for Europeans is I just point out that in the United States we have different states, and in New York City, just to point out, we have all these, I might be missing some, but we have all these insurance companies. And in order for us to determine whether we should be supporting a specific test, we would have to negotiate with all these different healthcare providers, and I'm sure you have strategies to deal with that. This is something we may need to do actively for us to get the type of reimbursement we want for this activity, but certainly it's a challenge. So obviously dealing with a lot of individuals is difficult, and sometimes dealing with one individual is more difficult, I don't know, but nonetheless, there should be a way that we're going to have to deal with the complexity of a very complex new approach to precision medicine, and hopefully see a way that it will make sense economically. And as I mentioned, we don't have necessarily better survival rates or life expectancy, and we're spending the most of any of the Western countries, and this is just an example. So as I mentioned, President Obama mentioned precision medicine in his State of the Union address now a few years ago, and decided that they would earmark millions of dollars for precision medicine. And I think this was amazing to actually hear this in the State of the Union address, that it fell onto the radar screen. And I think this is an important initiative. I was very lucky to be part of a group that was invited to the White House, and what I heard firsthand and what was obviously widely reported were three things that I think are very important to us and actually put us in a great position. And one is that the White House wants to have an initiative where we're going to be regulating what we do. So in the past, people are doing genomic tests in sort of a research setting, And the government is saying, if you do these tests, we really want you to do them in a setting that's approved, and they mention the FDA. So it's creating a lot of concern in the pathology community that this is going to be highly regulated. And for those of us in New York State, and having gone through a lot of the regulatory hoops we had to do to get our tests up and running, we recognize that this is almost something that we're really well positioned to do. We actually become leaders in the States, in the United States, for this activity, because we're so used to having to deal with the regulatory issues in New York State. And that also relates to reproducibility. A lot of the type of work that had been done in the past, and the concern about implementing precision medicine, is that we're going to have tests that are developed in all sorts of different research settings that won't be reproducible. The thing that was most exciting to me as a researcher and a clinician is that the president recognized and articulated that what we're doing is going to bring healthcare forward, but we are going to identify opportunities for research. And if we don't address these head on, then we're not going to make any advances in the way we treat patients. So, and he also said, which I thought was great, is that a lot of research ends without any wondrous paper or without a marvelous new drug or treatment. And so there's a recognition that we're going to have to invest, that this is going to be something that's going to be regulated, maybe by the government more than we want, and that it's going to also involve research. So there is this bridging of research and clinical care that's being recognized. I think it's very important. Our group has made a very strong argument that we need to connect, and this was what was artists try to show here, is that we need to sew together the genomic information with the clinical information. I don't know why they put dollars. I was hoping they'd put patients, but we wanted to really convey that in order for this to be successful, the electronic medical record that we deal with has to be combined with the genomics that we're developing to achieve a precision medicine. Now, one of the components that seems to be the area of greatest concern is the tests that we're running. We're running genomic tests that people view as very expensive. They're $4,000 or $5,000. Initially, they were hundreds of thousands of dollars, and now they're tens of thousands or 5,000, and actually going down to the single thousands of $1,000 or $2,000. The perspective, though, is that these tests are helpful in determining which patients, and this is an example from cancer, which patients are the best candidates for drugs that cost many thousands of dollars more than the actual tests per month and per year. Some of them cost anywhere from $100,000 to $200,000. So there has to be some economy in taking into account a relatively inexpensive test when you compare it to the drugs and the treatments that follow. And so in thinking about this, I mean, this is not a real formula. I'm a prostate cancer researcher, and we have a lot of interaction with Mike Milken, and he's very famous for developing formulas for Wall Street. And so just in thinking about Mike, I was hoping I could come up with a brilliant solution, but I don't think it's so brilliant. But the idea is that if we take into account the conditions that we're dealing with, the diagnoses, treatment, and benefits, and the costs, there has to be some model where the testing probably represents a very, very small fraction of what we're doing. And that tends to be the focus of precision medicine discussion. So people tend to focus on how are we going to get reimbursed for a $4,000 test, and not how are we going to take care of an individual, or how are we going to improve over a lifetime the types of decisions that we've made for that patient. So that's we want to think about it actually in the broader terms. And as I mentioned, Joe Biden, obviously now for very personal reasons, but also for, I think, the right reasons, is focusing on cancer, and has as recently addressed again in the State of the Union, is going to spearhead this moonshot approach to cancer. And I think that fits in very nicely with precision medicine. I think today, so the example from today that I saw was that a discussion from the Davos meeting where they recognize some of the issues. And so the issues are, how do we deal with the data? How do we incorporate this data into regular clinical care? And these are all some of the main topics that are floating around in the area of precision medicine I just wanted to bring to your attention. And the turning point, I think, will come when we see Medicare say that they'll start paying for genetic testing. And obviously the issue, as I mentioned before, is that there's no proof that if you do this test that has many, many results, that it is the test that you need to directly benefit the patient. And there's a lot of research embedded in that. So the discussion now is whether the White House has the authority to regulate this or not. And so I think this is far out of my area of expertise. But what I am seeing changing is I'm seeing the concept that this may happen as opposed to 3 years ago where this was so far from even being considered, it wasn't even on the radar screen, and it wasn't being discussed. And my best bet will be that this will be trivial 5 years from now, that this will be so obvious that we should be sequencing. And I know from personal experience running the Institute and working with families, patients, people that I encounter, when faced with a very difficult decision, they want the most information they can have. And if they can't get it reimbursed, they'll pay for it. And I think that shows what we should be doing. It's not necessarily what we can do on the larger scale, but it's what we probably want to do. So going back to this, I think there's a lot of work that we have to do at Weill Cornell to get this really integrated. We're working on it very hard to get our electronic medical record, working with Kurt Cole's group and others to try to figure out the best ways to integrate this large data sets into our electronic medical record, and thinking about this in terms of following patients for many years, not just for the initial event if they have a cancer or a biopsy or have elevated blood pressure, but how they respond over time. And we think this will be a wonderful way for us to engage our patients, and I'll talk a little bit about that at the very end. Just want to give you some examples of how this came from the research world, and I'll keep this at a high level, but I want to address one issue which I think is very important, which is that for our institution, I think for us to be leading in cancer care, other areas, we need to be the ones proposing clinical trials. We need to be the ones doing the work in the lab or discover something in a patient, go to the lab, and then say, this is what we should be doing, and then propose a trial, work with a company, and initiate that. This is the way our institution becomes leader in the field, prestigious, and also recognized as the place to go if you want innovation. So we were very lucky to work with a Stand Up to Cancer, it was called a Dream Team in prostate cancer, which we've published the results recently. And this team was made up of groups from a number of institutions. And the thing that I want to highlight is that we came in with the viewpoint that there are many clinical trials that are ongoing. Most of the trials have very specific reason. So they're testing a drug compared to another standard of care. The patients are enrolled. They do well, they don't do well, and usually that's the end. There's a paper that's written. If it's really good, it's in the New England Journal. If it's not quite as good, it might be another journal, and so on. But what happens is there's a lot of information that never gets captured. So the idea of our trial was that we would do precision medicine on each patient enrolled in these trials and be able to say what that patient should do after they fail the trial, which is in prostate cancer, and this is what the trial was focused on, very common. So after the common lines of treatments, patients fail, what do we do next? And we orchestrated this in a very, I think, important way where each group had some major role, and I think this was a great experience. This actually gave us a head start when we started our precision medicine program, because we knew about some of the complexities And we had to develop standards so that we knew at all the different institutions we were doing the same things. And luckily, we played sort of an integral role in the pathology part, but also the analysis part. And I won't go into all the details of the types of sequencing and the methods, but really this was all cutting edge. I mean, at the time when we proposed this, there was nobody doing whole exome sequencing. And I'll describe what that is. That's a very large test compared to the targeted sequencing. I'll show you what that is in a moment. That was being routinely performed at the time. We were proposing something that really was viewed as entirely research-based. And in our scientific report, we described in red some mutations or alterations in genes that hadn't been seen in patients who hadn't been treated. So we started seeing an emergence of mutations that are occurring during treatment. So that also brings up an important point, is that many of the standard of care approaches are you have a biopsy for a disease, whether it's melanoma, lung cancer, breast cancer, and using that information, you then decide what treatments. Patients receive treatments, and we change the way that tumor is growing. We select out the cells that are going to now be resistant to the treatment. So we need to actually follow that. So in this study, we perform metastatic biopsies. We're also performing liquid biopsies, where we're taking blood and analyzing the blood for alterations. And in this manner, we can identify what are the reasons for resistance. So that's a new thing that hadn't been really done before. So as I said, this was viewed as a research study, not really something that was going to impact clinical care. I just want to highlight one finding. So one finding was that we saw a very high number of mutations in a pathway called DNA repair. So you imagine you have DNA, you've got 3 billion base pairs in each cell, and if you don't have the machinery that takes care of it and maintains it, it's like, the city streets towards the end of the winter, we have potholes, and well, this is exactly what's happening to tumor cells. They're having all these genomic alterations. They continue to grow and become more and more aggressive. What we found in this study was that unexpectedly, when you did the sequencing, you found that patients had very large numbers of these DNA repair mutations. It was previously assumed that it was probably less than 5%, and we found it anywhere between 10 and 15%. In our population in New York, we have a very high number of Ashkenazi Jewish individuals who have a higher risk of having these, what are referred to as founder mutations. Why is this important? Well, this work was reported in the New England Journal because there's an inhibitor called a PARP inhibitor that if you have one of these mutations, you can take advantage of that and you have a double hit. So the tumor cells have one problem and you hit it in another area, and that leads to what's called a synthetic lethality, or you can actually kill the tumor cells. And in 30% of the patients in this initial trial where we did no screening, we saw long-term responders. And this was a study that was carried out in the UK and also in Michigan, as well as our Stand Up to Cancer group. So this is a first example of identifying a response with this drug. And when we went back and looked at our genetics, we found that it couldn't be explained by one gene, but it was explained by a number of genes. And so this in typical clinical studies, you look at what are referred to as Kaplan-Meier curves, and the patients who do well are the ones who obviously have higher survival in blue. And it turned out that if you had one of these mutations, you were in the group that didn't do as well. And this highlights the fact that had you used a standard test, you would have missed probably 50 or 60% of the mutations that we identified. We had no idea going into this study that that's what we would find, but that's what we found, and it helped explain that. Now, why this is important is that the very next clinical study that's going to be done is a study that's going to be designed totally differently. So the next study will be designed in a way where we're going to say, let's do the test up front, and then if you have a mutation, you get the drug. If you don't have a mutation, we're going to think about another drug. And so that's the concept of precision medicine, and we've already demonstrated in our 3-year Stand Up to Cancer study. So let me turn to Weill Cornell's activities, and this was also published. We think publishing is not bad. So the idea that we're publishing in scientific journals is important. It's peer-reviewed, we're transparent. We want everybody to see our standard operating procedures, our protocols. We want to publish the technical part because we want to become the standard for how this is done. We want people to come to us, and there are no textbooks now, but if somebody were to write a textbook, we'd want to be featured in that textbook as the way to do the various things that we're trying to set up. I won't go into all the details, but in order to do this, we started as a research program, and it was a very ambitious program. We worked closely with Steve in the Dean's office to really identify a way that we could have sufficient support to start a program that would allow us to do all the things we had done in Stand Up to Cancer and more. And I won't go into all the details of the protocol, but one of the things that we made sure is that anything that we do, we make sure we biobank. So in case the patient needs to have studies done later, we'll have material. And we also had an ambitious program to develop organoids or avatars of the patient's tumor cells. And this falls very much into the area of research, but I want to show you one example at the end where I think this will be part of standard of care years from now. So the approach that we took for our program was to make sure that we connected the clinical treatment, electronic medical record, and the next-gen sequencing, or this high throughput type sequencing we were doing all together. And we haven't quite completed that, but as I mentioned, I think the last hurdle will be working with Kurt and his team to try to connect that. And once we achieve that, I think we've achieved something that probably less than 5, but probably only 1 or 2 other institutions will have achieved in a meaningful way. So we can do it in a manual way, but we really want to achieve this, and we're working hard to do that. One of the things we learned early on is that this is a process where we have to communicate really well, and I always think of my father and brother who are clinicians. My brother's Ivy League educated, a very bright guy, but they don't understand genomics, and as doctors we need to communicate the important information to them so that they can communicate it to their patients and to the specialists that take care of them. So one of the things we have to recognize is that what we're doing, even if it's first-in-class genomic sequencing, it's got to be communicated. We have to make this something that can be used by the clinicians and understandable by the patients. So we work very hard in that. And we've created an internal system to try to track all the information and then hopefully feed it back to the patient. We have, because of the complex nature of the genomic reports that we have to have discussions in tumor boards that now also feature not only oncologists and pathologists or surgeons, but now we have computational biologists and molecular biologists. And so I always say the best room when we have this precision medicine meeting is when it's full of all sorts of diverse people and includes Lou Cantley, because when we have Lou in the room, it has that special moment where he just says, aha, this is what we need to do. And he knows the trials. I'll get to that in a moment, but the point is that we don't always have all the knowledge we need. So part of what we need to do is we need to create systems to create knowledge bases and share. And so going back to our Stand Up to Cancer approach, we probably will need to partner with other institutions. So obviously Columbia would be a good one, but we will probably need to go broader because we'll need to think of crowdsourcing to understand some of the things that we're finding. This is just a snapshot of some of the tumor types that we had in 2014. Now it looks quite different. So now we have fewer percentage prostate and more other types of tumors as we move forward. And I think this is a few months old. I think I saw the number 780, so we're close to 800 patients that have been enrolled and that we've done genomic sequencing for precision medicine program. One of the standout features, I think, of the program is that we have, similar to our Stand Up to Cancer study, gone after lesions that are metastatic. So this was one of the first challenges. We had to partner with interventional radiology. We worked with them and developed a protocol, and now we're capturing biopsies from patients who have metastatic disease. Now, normally in standard of care, you would not necessarily biopsy a patient with a metastatic lesion. So when people ask us, well, what do you see? 2 years ago, we would say we have no idea because we don't look. We never look. You just treat a patient, they have pain, or you can see radiographically that they have a new metastatic lesion. Now we're actually biopsying them. And the next step will be probably better, which will be we'll just take blood and we'll analyze it. We can do a lot with our genomic testing. This is just to show that the very first step of what we do is we could actually look at the single nucleotide polymorphisms, or the changes in the DNA, the changes in the letters that distinguish one person from the other. We have probably 99% or greater percentage of our 3 billion base pairs in our genome are similar. The few that are different make the difference between the different types of people we see in this room. And it's very important. Now, this information is important because as we think about why a patient is responding or not responding, we want to also think about what is their ethnic background. It turns out that most studies have been conducted in European males. And so we want to, as a hospital system, as a network, we want to think about how our patients are responding, also based on other aspects. And this is part of our consent. So we very clearly describe what we are doing. But I think it's important. And as we move forward, we want to be able to say, in the setting that you're in, we don't know because we've never seen an individual who's come from this ethnicity, or we know that, let's say, somebody from South Asia may not respond to a drug in a certain way. This is some of the sophistication that we can add using a genomic test. Just give you one example from a tumor board that has been widely publicized, and there's actually videos on the website and have been recently reported in of all places, New York 1. So I saw, my mother saw it, I was away. She thought it was great. So I don't know if it was great, but she thought it was great. So this is a 75-year-old woman, a really energetic woman who had bladder cancer. She had first high-grade bladder cancer that was localized, and we performed the standard of care here at Weill Cornell. Then she developed metastatic disease, and at time of surgery, there was a biopsy done, and the sequencing was performed. Now, one of the findings is that we deliver a report, and the report shows typical pathology. It describes what we think are the most important genomic alterations, and that's what we discuss in the tumor boards. And in this patient, she had an overexpression of a gene that's altered in breast cancer. It's called HER2/neu. There's a drug for it called Herceptin. And in breast cancer, you would, without question, move to the next step, which would be to give the patient Herceptin if you have overexpression of this gene. It's a gene called an oncogene, and it drives the tumor to progress and outgrow the surrounding tissues. This patient was faced with a situation where there were no trials in bladder cancer showing the efficacy of this drug, but nonetheless, working with David Nanis and Misha Beltran in oncology, it was decided and eventually approved by the insurer that the patient should get Herceptin, and she's had a dramatic response. And although I don't take care of patients firsthand, in working with David and Misha and hearing the experiences, and actually the woman's experience, she explains very nicely herself, is that we're talking about individuals who would die of disease, like this woman, if she wasn't treated with Herceptin, and who ends up extending her life, and she hasn't had a recurrence yet, being able to go to weddings, see grandchildren born, and have the experiences that we want to see. So we may not be able to cure cancer, as the government is trying to, and Joe Biden's trying to do, but we certainly can extend life if we have the right drugs and align it to the right patients, and also, I think very importantly, extend the quality of life, which is what we want to do. Now, this looks like something either from a textbook on diversity or of populations, and you may, if you go to the Museum of Natural History, think about the charts you see going from the ape to to the human, various different species. This is what we are reporting in scientific publications, going from the first tumor and showing how it evolves and their different mutations. And this may look like something that we would put in a research publication. I'm hoping that 2 or 3 years from now, when we see a patient the first time, we'll sequence their tumor. 2 years later, we'll look at it again and we'll follow it. And we'll be able to create these types of charts, and that'll be part of the medical record where we'll be describing how the patient's tumor is evolving and think in a more complex way about how we should be treating it. And so although this doesn't look like something we'd put into a report today, I imagine that we will be. And this is an example of a bladder cancer that was sequenced multiple times over multiple time points where we could address what were the changes due to treatment. So I just want to get to the crux of our tests. The typical tests are targeted tests. And so if we think about the genome as having 3 billion letters in the genome, only a very small percentage create proteins. And so that's depicted here in what's called the exome. And then of those, there's probably only a small percentage right now where there are drugs, and those are referred to usually as actionable. So most of the hospitals develop a very small panel. We have a very nice 50 gene panel that's approved of genes that are known to be actionable. There's a drug, so if you find the mutation, you can do something, or you know that you shouldn't do anything because the drug won't be responsive. What we've done is we've moved our tests, and the tests we're using is whole exome. So we've extended it beyond actionable. We've extended to all protein coding genes that are known. We're not doing whole genome, which would be taking all the coding genes and then also the vast majority of the genome, which is called non-coding. It's also referred to as a dark matter because people don't really know what was going in. I think we're learning more and more about it, but that's something that we think probably will also be included in a regular test in a certain setting. And this year at the American Association for Cancer Research, I'll be giving a talk. It'll be a debate on whether we should do targeted sequencing versus exome sequencing. This is one of these debates where if I waited probably 3 or 4 months, I don't even think there would be a debate. I think we're moving so fast towards doing larger sequencing for exome sequencing as opposed to targeted sequencing. That said, there are advantages and disadvantages, and the targeted sequencing has a major advantage that you cover it so deeply. In other words, you have so much support for your finding that you can with great confidence say in the few genes that you're looking at that you have a mutation or you don't. We're looking much more broadly, so we're at risk of missing things. So right now what we're doing is we're combining targeted and this broader approach because we don't want to miss anything that's actionable. In the future we'll create a spiked approach where we'll have deep coverage where we need to, but then be able to canvas as much as possible. And the idea is that in every instance where somebody is being treated for standard of care and they do well, that's fine. But what happens when they don't, and what happens when they fail? We want to know the information. In every instance that I've been asked to consult, and when we've talked with families and friends, everybody wants to know as much as they can. And so I think this approach allows us to say we've looked at everything and maybe we have nothing to offer, but at least we looked. And so that's the strategy, and I think that's a tremendous motivation for patients right now. So the Exact1 assay, which stands for exome sequencing of cancer cancer tests, exome sequencing cancer tests, is the test that we're using. We have a test that combines not only the sequencing part, but the whole informatics pipeline, which I won't really discuss in any detail today. But Olivier Elemento is leading our team, is a researcher who's established in the field of the research of computational biology, but he's also applying his expertise into the clinical care. And we're developing state-of-the-art approaches to analyzing. So the way we see it is the Exact1 test is a test that is a sequencing, but really everything included all the way to the package of the report that can be delivered to a patient. And this was submitted to New York State, 1,000-page document, took us 2 years to get through New York State. And we could have long discussions about that. I mean, it's very painful. So this is what the system looks like, and we have sequencers, but then Olivier's put together high throughput sequencers that require a lot of data management. So he's put together the infrastructure initially in the ICB, and now working with Kirk Cole, we're addressing the issues of how do you do this in a way that you're compliant with all the things you need to be compliant to working with patient data. So we're working very closely, and there is no textbook, so we're solving this as we go, and using good judgment. And I think this will be, when a textbook is written, I think will be hopefully in the textbook as a way to have solved this problem. And just one comment. So we have a test that can look for mutations, and that's great. But our test, as I point out, can also tell you the ethnicity of a patient. That's great. It can also tell you a lot more. And so just one other example is you've heard probably about immunotherapy being a very exciting new type of cancer therapy. Immunotherapy is effective in a percentage of patients, sometimes 10%, sometimes 20%. So in lung cancer, it shows maybe being effective in maybe 20% of lung cancer patients. In melanoma, maybe 20%. In other cancers, it may only be successful in a small percentage. There's no real test to tell us who's going to respond and who's not going to, but if you do respond, you're going to have a very dramatic response. So one of the things that Olivier's group is developing is using the same test, just coming up with different ways of analyzing the data. Can we make heads or tails of what's going on, not only with the tumor cells, but also the normal cells? How is the immune system responding? And so that's obviously a work in progress, but it's something that we want to be leading so that when our patients come, we have an ability to tell them targeted therapy, immunotherapy, chemotherapy, what's the best for you. As I mentioned, we're developing databases, and this is something that is quite challenging. You would think that you would have some place to refer to. It would tell you when you find a mutation, that's a bad mutation, that mutation you should ignore. The reality is that this has been a cottage, sort of a boutique industry. Every group has their own little database. It's not shared information. And so one of the goals that we have, and that we think to be leaders, is coming up with the approaches to do this internally, but then also to practice a crowdsourcing or some sharing method that will work with partners to share data and also improve our ability to, take care of our patients. So that's something we're working very hard on. We're developing ways to monitor our process. So this is something where we very early on knew that we would have to maintain understanding of this as process where we have hurdles in sequencing. Sequencing right now takes about 5 to 7 days in the standard approach. Now this is okay. We want to actually accelerate as much as possible. We've been able to sequence in 4 or 5 days, but over time that'll become shorter. But we really have to monitor our ability to do this and understand if we offer these tests, can we actually deliver it in a turnaround time that's relevant for patients. And we're also thinking that for us to be effective, we have to have ways for the clinicians to be able to look at the data, potentially also patients, and look at it in a meaningful way. And one of the ways we'd like to do it is to have them log in. They'll see their patients, and they'll also be able to see their patient in the context of patients with similar disease type that they have, and they would be able to create very specific searches related to that. And it has to be easy. It has to be something that they can just readily log in. If it's a bladder cancer, it would show you your patient is very standard. They have the same mutations that 95% of patients have, or they're an outlier and they need to have a different type of treatment. And that's one of the things that we think is very important. For another reason related to our own sanity, we want to be able to have the clinicians log in and say where exactly the sample is in the process, because we don't want to be answering the phone all day it's on day 2 of the sequencer, and then 3 and 4 and 5. And so over time that'll become shorter. But we think to manage this, we really want to make sure that the clinicians are very much connected to what's going on in the behind the scenes. Now, the last thing I want to just focus on is the concept that this will lead to research. And this is where, in discussing with the hospital and thinking about insurers, it's hard because we don't want to pay, for research necessarily from our clinical care dollars, but in reality, most of what we find will open up the avenues for research. And this figure that we put together was intended to show in the bottom where we have dark arrows. You can't really see the names of the genes, but those were genes that if you found them, you could readily treat a patient. And what we show as you move up to category 2 and then category 3 there are a lot of genes that we're finding that are mutated, but we don't know what to do with those genes. And so that does not mean that we just put them into some sort of filing cabinet and forget about it. It means that we have to have it on our system, and we have to have some way of prioritizing. And so one of the, I think, advantages of being part of a world-class medical school is that we have researchers who are interested and also collaborators that they have that may be interested. And we really need to take advantage of that, prioritize it, but take advantage of that. And we need to do it also in real time if we want to make it useful for the patients that we're treating. So one technology that we're using, I'll just describe briefly, is the concept of an avatar, or what we refer to as an organoid. But basically you're taking a patient's tumor cell once they've had a biopsy, and we're trying to grow it. And this was based on a scientific study led by our collaborators at Memorial, and our group was very much involved in the genomics and providing samples. And now we've set it up in our own lab here in Belfer. So when patients are enrolled in precision medicine, we perform the biopsy. We take some cells for sequencing, some for diagnostics, but then we're also creating organoids. This is an example of a sarcoma that was grown, and all the little dots that you see represent large clusters of tumor cells that are growing. And you can imagine that if this really worked well in the dream that we would have, you would treat each cluster with a different drug, and you'd say, what's the best drug for that patient, knowing the types of drugs that they may receive. So last comments I'll make relate to the precision medicine initiative. Just a few comments about that. It's a very ambitious initiative by the government. The idea is that we would create a population that we would follow. We'd identify a population, enroll a population of about 1 million individuals, and over time we would follow them. Do they get congestive heart failure? Do they get diabetes? Do they have diabetes and then go on to have something else? And the idea is that if we do this, and it's done in a way where we represent all the different ethnic groups in our country, that we will learn an enormous amount. And one thing that I've seen that really is, I think, been amazing in interactions so far that we've had with this initiative and the White House directives, has the concept that now the patient should have their data, and the data should be shared. And if that patient wants to have their data sent to another institution to do research, you don't fax it, you send them the data. So Olivier Elemento's group has to send the data, not an office where we have a fax machine. I don't know if we have fax machines anymore, but that was the example that was given. And so the idea is that we're empowering patients to have control over their own health care. And there's actually rules and regulations that are being developed that were actually quite different than any of the discussions I've ever had before when I was at NIH or NCI discussions, where the discussion was always the fear that somehow these data would be, the patients would get the data. And now it's really the opposite, is that they really want to have the patients involved very much in their own data, wearing portable devices, could be their cell phone, could be their watch, could be their ATM card that tells you various things. And we met with an expert at Cornell Engineering who is going to be part of a team I'll tell you about, and we're going to be thinking about every way that we can capture data. when I give this presentation, I always think that this quote fits quite well. We tend to overestimate the effect of technology in the short run and underestimate the effect in the long run. And so I think here what we've done is, for precision medicine, we've invested in an infrastructure. We're building on it. I think that's the right approach. We shouldn't be short-sighted. We should look at the long game here. And I think that this has been exciting. So where does it fit right now in our current paradigms? Well, we're already seeing the oncologists develop trials where we're using precision medicine. This week we've been submitting grants, and we've been thinking about trials and grants where having precision medicine in place leverages us to get all sorts of other resources. I hope it'll encourage patients to come here versus some other institution. We have ability to create drugs, and so what I just point out here is that in orange there may be some cases where we have actionable individuals, but most, as I point out, of the individuals that we enroll, we won't really know what to do with the results. And so we have the framework that's been developed over the past years through the Dean's initiatives and previous Dean's work to set up a setting where we really can learn from each case and potentially even create the drug that would be used to treat the patient. So I think we're in a very exciting era. I would just like to acknowledge this is probably outdated. I think the number of people is probably twice as many now, so we have to update this. I would point out that Olivier Lamento and Misha Beltran have been wonderful partners in sort of getting all of the logistics together. It's expanded out. It's really expanded quite a bit. As I mentioned, Kirk Cole's here. He's been working with us now to really operationalize this and get it working in the hospital setting. And as I point out, you can see we have executive producer Steve Cohen, who's been a wonderful partner in this. We've really thought through a lot of scenarios. He mentioned the New York Genome Center. We've had to think about how do we go from a few hundred cases a year to thousands of cases, and that's one of the issues. And obviously we've had to think about cost, and obviously with scale it becomes more efficient, but we also have other logistical issues to think about. So I wanted to give you an overview of precision medicine. I've hopefully done that today. I'm happy to answer questions. I know that we have time, and there's also a drink afterwards, and I'll hang out and talk with you then. So thank you very much for your attention today.
So Mark, we have time just for a couple of questions. Let me ask you the first one. You talked a little bit about the precision